Well, hello and welcome to our academic activities. Today, the presentation is going to be about immune therapy. To introduce, I would like to ask the name of this angel. Well, if you ask men, you're going to get more the possibility to get an answer, because in these religious issues, seems to be that men are more knowledgeable than women. And it's a fact, if you ask any men about the names of several angels, they're going to come out with the whole list of Victoria's Secret's angels. Well, just kidding. This is an guardian angel, so it doesn't have any specific name. For each one, there is a guardian angel, according to theories. And actually, there is some pictures that were taken by some paranormal activity hunters, ghost hunters, and we're gonna show you. You wanna see it? So we're gonna show the picture of these guardian angels. So we had here, these are 6 different guardian angels. So for sure, neutrophils, lymphocytes, monocytes, eosinophils, basophils, all of them are our guardian angels. And if you don't believe that, think about the following: that for every single liter of blood that you have, there are millions of these small soldiers that are gonna give everything for you. So don't feel any more alone. Somebody's taking care of you. Well, in the past, the immune system was not well understood. Even 60 years ago, some children that present with some shortness of breath, it was thought that it was caused by a huge thymus. And for sure, when you are a child, your thymus is big, is with a huge cellularity, and is big. But that time there was not like a really understanding of what was the role of the thymus, because they said, well, when you get older, there's not going to be any more thymus. So what happened if we just shrink that thymus with some radiation, and maybe the child is going to get a better respiratory pattern? So that was the thinking of more or less 60 years ago. Nowadays we understand a little bit more about the immune systems and know that this is a system that is not based in organs, but more based on cells, as we can see here. So, ouch! What is the first response of the immune system when, after these bacteria, foreign bodies, are going to pass the first barriers like the skin, like the mucosa, like the acidity of the stomach? They got inside the tissue, and the first response is going to be an automatic and innate immune response that is not going to be specific, but because after this first approach to the disease, to the infection, we cannot be that specific. We just have to launch a response that it has to be fast. And then, as you can see here in the bottom, there is chemotaxis by these histamines that are released by some cells after the tissue damage, and this is going to produce the migration of these neutrophils that are going to go inside and going to shoot and destroy, and that's it. It's not specific, just go and kill. Well, this is the first wave of response. After that, they're going to start a second wave 6 hours later. We're going to see the proliferation and migration of the monocyte macrophages that are going to reach the inflammatory site, and they're going to do the same. They're going to phagocytes, but this is a different story, because this is like the middle point between the innate, non-specific response and the specific response. We're going to see how. So this is the macrophages. They just phagocyte the bacteria or the viral or tumoral cells, and they're going to chew, destroy with lysozyme enzymes, degrade those proteins to peptides, that is small pieces of protein. And these small pieces of protein are going to be presented to the specific immune system. And as you can see, this blue square here. This is like, let's say, a hand that holds the peptide. This hand is called the major histocompatibility complex. That's going to be like the hand that presents the ID of the foreign antigen, the bacteria or virus that has been degraded by the phagocytes, and is going to be presented the ID. It's going to present this antigen to the lymphocytes in the lymphatic tissues, lymph nodes. So remember, major histocompatibility complex is going to present these peptides as an ID or identification of the foreign pathogen that is attacking the body. You're going to see here. So again, we saw, for example, here a virus that is going to be phagocyte, but this macrophage is going to be destroyed, and the peptides are going to be present to the lymphocytes in the lymphatic tissues. So more or less it's like this. It's like the Godfather. The Godfather is going to get some information. The Godfather is the T helper cell. It's the lymphocyte that is going to get the presentation of this antigen by the macrophage. That is going to be the informer what is going on in the body. After he got the information, the Godfather or the lymphocyte is going to launch a response. It's going to direct the response, as we can see here. It depends on what type of bacterial virus is attacking the body. Some of the pathogens are extracellular, so are in the lympha, are in the blood. So when it happens, the T helper cell is going to direct the response to the humoral response. So it's going to direct the response extracellular to this activation of these B cells, lymphocytes. These B lymphocytes are going to differentiate in plasma cells that are like the gangsters with machine guns. Just going to give a rain of immunoglobulins to attack in the different parts of the body these antigens or bacteria that are infected the body. When it is not extracellular, then the CD4 is going to direct the response to a cell-mediated immunity. So when the cells are infected inside, like this infected cell with virus, the response has to be specific to target these cells. So this T helper lymphocyte CD4 is going to differentiate to the cytotoxic T cell lymphocyte. How it's going to work? So this is not like the machine guns. This is a close contact battle. This T cells, this cytotoxic T cell, is going to get in close contact to the affected or infected or the tumoral cell. It's going to open some holes inside the cell with these porins. Porins is going to open the holes, and then it's going to degranulate some granules inside the cell to be destroyed from inside the lysis of the cell. So this is a close contact battle, very specific to don't cause too much damage to the other cells in the environment. Also, there are some other cells that arrive when the party is on, when the inflammation and the pathogens are being fighting. There is arrival of some other cells that attack these intracellular pathogens or cells that are damaged with some mutation in the case of cancer. So this is called the natural killer cells. This is like Hannibal Lecter on drugs and with an axe and a machine gun. You just arrive and you just kill everybody. So this is not really specific, but helps with this cell-mediated immunity. Once we have all the clearance, there is no more infection, there is no more tumoral cells. What happened? We had to just down-regulate this immune response, and then we call our lymphocyte, that is regulatory lymphocytes. That is going to just say, hey, hello, stop a little bit because you are creating too much inflammation and you can cause damage to the tissues, and then we can create autoimmune disease. So by several markers, cytokines or molecular signals, this is going to stop the immune response to down-regulate it and to stop it definitely. Some of the molecules that are available to do this break is CTLA4 and PD-1 molecules. This is very important to know because that's what we are going to talk about today. CTLA4 and PD-1, like the brakes of the immune system. All right. So when it is stopped, no more cells, all the cells go apoptosis, just left the remains of this infection. So just memory cells. These memory cells are going to say, hey, I remember you, just in case this bacteria or virus appears again. Thus these guys are going to be able to identify and launch a more effective, more faster response. So you get infected by a virus, you're going to get the complete symptoms, but after the second encounter occurs, you're going to get infected, but you are not going to even feel the symptoms sometimes. So for sure you can get chickenpox infection twice, varicella, but you are not going to develop the full symptoms, the papules and vesicles and blisters, no. Because these these memory cells are already trained, and the specific response that takes sometimes several days is going to be immediately. It's going to take place immediately. This is the mechanism by the way we create immunity with the vaccines. You just get a vaccination, stimulate the immune system, and the next time the memory T cells that we create with this vaccination are just going to act so fast that the infection is not going to show up anymore. Well, these are antibodies here. In the bottom we see the antibodies, how they work. They are specific for a specific condition. So you have millions and millions of lymphocytes. Every lymphocyte in your body is dormant, is sleeping. This lymphocyte is just going to get activated and it's going to produce antibodies whenever it is sensitized or is going to be activated. But that specific antigen that is going to be just like a key for a card. If the lymphocyte and these lymphocytes does not get in contact with that specific antigen, that lymphocyte is going to stay dormant. So what does it mean? We have specific lymphocytes are sensitive for a specific antigen. Let's say we have in our body some that are very specific for rabies, for another one for dengue, for chikungunya, for malaria, for all kind of antigens, particles of viral infection, bacteria, parasites, the proteins in the pollen that are there. We have a specific binding site for a specific lymphocyte. If you never get in contact, for example, with Ebola or with chikungunya, then those lymphocytes are susceptible to be activated by that specific antigen are going to remain sleeping forever. But by some chance you get in contact with any of those antigens, then you're going to start to develop the proliferation for one lymphocyte. After 1 week of activation, you're going to have millions and millions of lymphocytes. This is a clone expansion of that lymphocyte to amplify a very, very specific target response for one specific antigen. In this case, we have here this antigen binding site that is specific in this case for one of these pathogens, and as you can guess which one is the specific binding site. No C, no B, no E, no D, but probably A. So that's the way it works. And why do we have such a big specificity? It is because of the molecular shape of this variable binding site. As we can see here, this is called a hypervariable region, where hundreds of billions of possible shapes are formed. So we had 100 billions of possible shapes. So that's why we had that variability, and our immune system is able to identify more than 100 millions of different substances during our life. Very interesting. Now, the antibodies, what is the function? We can see here in the upper right side how the antibodies are surrounding some bacteria, and is creating some opsonization. What is the function? Thanks to this opsonization and this labeling of these microbes, the macrophages are 40 times more diagonal phagocytes, 40 times easier these microbes, thanks to these antibodies. Some other functions of antibodies, for example, they can block the flagella in some bacteria, the Vibrio cholera, for example, and does not allow that bacteria to escape of the immune cells. Some cause agglutination of bacteria, making them less likely to be spread in the body. But in today, lecture, it is important to identify one specific function of these antibodies, which is the blockage of receptors, the blockage of molecules, the blockage, like in this case, this antibody, you can see here in the bottom, here, this antibody is blocking the active site of an enzyme, in this case, snake venom enzyme. So it's going to inactivate, and it's going to inactivate the venom. But you can see antibodies that activate or inactivate some receptor in so many other examples that we're going to see later. Well, our friends, the lymphocytes, they are produced in the bone marrow, and after, in the first months of life, all of them are going to migrate inside the thymus organ, the gland. In the thymus is like the school, police school for the lymphocytes, special forces. These lymphocytes are going to get inside, but for every 100 lymphocytes, just 1 or 2. 1 or 2% of them are going to pass the school and going to get graduation. The rest are going to die, going to go on apoptosis. Why is that? Because this has to be very, very specific response and delicate balance in the immune response. Because if we have lymphocytes that are like this, very lazy, they are not going to be useful. They're going to completely be useless, and they're not going to be able to fight infection. So we don't need this kind of lymphocytes. So the ones that doesn't react, they're going to die in the thymus. By the other hand, if we have lymphocytes that overreact, that are very aggressive, they are not going to be useful, because if you got these lymphocytes all around your body, what they're going to cause is damage and autoimmunity. So we have to get the right balance between the elimination of infection and the no cell attack to your body to avoid autoimmunity. Remember, lazy lymphocytes decrease the autoimmunity. Okay, there is no autoimmunity, but the infection is going to proliferate because we don't have warriors that are going to be ready for the fight of infection. By the other hand, we have these lymphocytes that really are very aggressive, and they are going to crush the infection, smash the infection. Yes, okay, but what about the autoimmunity? Probably going to have some problems with autoimmunity. So it is a delicate balance. We can see it in these different types of hypersensitivity reactions. That is type 4, type 3, type 2. Type 4, we have poison ivy disease, late autoimmune reactions. And type 3, we have all kind of autoimmune complex disease like the myasthenia gravis, Graves' disease, rheumatoid arthritis, lupus. Type 2, we have all the autoimmune lysis, the mother that pass antibodies to the fetus and produce hydrops fetalis, and so on. If we talk about these 3 different types of autoimmunities, we can engulf almost 3 to 5% of the population. But if we have the type 1 hypersensitivity reaction, that is the classic allergy, like asthma, like angioedema, like urticaria, then we're going to have almost 30 to 40% of the population that is affected. So despite of the high level of selection in thymus, we still have this problem. So the immune system is a really, really delicate balance. You're going to see. One question, I would like to know, what do they have in common? It looks like, well, one answer is that they manage the force. This guy talk about the energy is equal to m by velocity of light, and this talk about the use of the force. I'm just kidding again. So the real question is, what do they have in common, these 4 guys? So what they do have in common is one thing. This guy, the bottom, this Jimmy Carter, won the Nobel Prize winner. He's a real Nobel Prize winner, by the way. This guy was a physics, Albert Einstein Nobel Prize winner. And these 2 guys happens to be the 2018 Medicine Nobel Prize winners. Okay, another question, a little bit more difficult. What they do have in common, that is not a Nobel Prize. Well, it happens to be that Jimmy Carter got a melanoma 2 years ago. He was diagnosed by a metastatic melanoma with metastasis to the brain. The expectancy of this type of metastasis melanoma is 6 to 7 months of life after the diagnosis. So what happened? 2 years after, and he now is playing golf and go fishing. Survived. It's something that doesn't happen before. But the relationship is that with the development of the immune therapy, new therapies that these guys help to develop, they developed this therapy that helped to cure him. After 2 years, he is now free of melanoma, thanks to these two guys. When in the fight against cancer, the first recordings in the history is in the ancient Egypt, where they call it the disease without cure. But where were the Greeks that they call after canker, after crop? Canker is the name of the cancer because for them the malignant tumors just remind them the crop. The form and the legs looks like the blood supply to these tumors. So it's a long history. Since then, the last couple of decades, we have developed new technologies that have increased the survival. We saw here in blue the survival and decrease the mortality in cancer. So we are doing, let's say, well in this battle against cancer. But as we can see it here in the breast cancer, the incidence increased with the age. Among females, 1 of every 8 females is going to develop at some point in their lives breast cancer. So it's the most striking tumor in female population. But thanks to the development of these technologies like radiotherapy, focused radiotherapy, new techniques in surgery, chemotherapy, the survival rate of these patients is 90% after 5 years. So it's pretty much a good survival rate, because if we thought 30 to 40 years ago was less, like 50% or less. So the development of these new technologies has really changed life expectancy for these patients. But despite of that, we had certain tumors, like this DIPG, in the children population that is very aggressive. And despite all the therapies, the median survival rate is 9 months. This is because the growth of this is growth inside the both hemispheres to the corpus callosum, and so it made it not likely to be operated. And the hematoencephalic barrier does not allow this chemotherapy to get inside the tumor. So it's like that. And other tumors in the adult, for example, the mesothelioma related with asbestosis, has a survival rate of just 12 to 20 months because of the pattern of growth of this tumor that made it really, really difficult to operate. And it's very susceptible to radiation. But what happened? But when you radiate the mesothelioma, it's more likely to kill the lung tissue before you kill the mesothelioma. So these kind of tumors are challenged even for the new technologies and therapies that we have now for the cancer. So what's going to be the future? What do you think about this? So what do you think? Is Star Wars like let's say this very futuristic? Just put this nanobox with a syringe in your bloodstream, and they're gonna go and look for cells, identify the cells, and kill them or repair them. Yeah, there are too many technical issues to be able to reach that point yet. But I'm gonna tell you that we already have some nanobots that are really efficient into search and destroy cells of cancer. We're gonna see them. I'm going to show you the video of these nanobots. So we have the nanobots here. Yes. So these are the nanobots. This was a tumor cell, and they are just kill them. You see it? These are the real nanobots. The nanobots are our immune system cells. Those were natural killer cells. And you can see here another killer cell killing not a tumor cell. In this case, was an infector cell. As you can see how this is shrink. The lysis of this cell by the destruction of the membrane by this natural killer cell. As you can see, these cells are just that effective. It doesn't matter the size, they just do it, go after and kill. This is not a tumor cell, but this is a Diplococcus. This is a bacteria. This cell is followed by this neutrophil. They just follow until it's engulfed and die. So this is the way they work. They work 24 hours a week, 24 hours a day, 7 days a week. This is a small cell that moves very fast around these tumoral cells. It's a engineered T cell, cytotoxic T cell, and we see they just kill a cancer cell and go after other, and go after all. That's the stop. So these machines of kill cells that are infected or damaged by cancer, by these cytotoxic specific T cells that just kill a cancer cell and go after another, they are so efficient. It has so high efficiency in doing that. So just go after one cell, doesn't stop, go after another one, and another one, and another one. And if there is not enough of these cells, they just go mitosis. And after one single week of mitosis, they just pass from one single lymphocyte to 6 million lymphocytes. So this is crazy. They are very effective at this, and unstoppable supply of lymphocytes, and they're just doing they work so efficiently. So we saw here how they surround these tumoral cells and they kill it. So that's it, no? So this is the real nanobots, the real army inside us that are fighting 24 hours a day, 7 days a week, all kind of intracellular dysfunctions by bacteria, viruses, of mutations that lead to cancer. So you can see here one more time. So that's it, no? Very, very interesting, very interesting, and very amazing how they work. So what the question is that if we have such an army inside our body that kill in that way efficiently these tumoral cells, why cancer still be present and still be the second killer after cardiovascular disease? What do you think? So let's think about that. Somebody is fan of Star Wars. Do we remember what was the reason why the resistance, the guerrilla troops of the resistance, were not able to attack and launch a direct attack to the Death Star to kill or destroy the main weapon of the Empire? Yes, because this Death Star was surrounded by this field of force. This energetic field was launched from one side and surrounded the Death Star, and does not allow any fighters to get inside the Death Star and destroy it. So it's the same with the tumor. The tumor has such a big amount of shields that protect that tumor and those cells for the attack of the immune system. First of all, around the tumor there is most of the time a fibrous tissue that does not allow this the immune system cells to infiltrate that tumor. And then this is called genome instability and mutation of these cells that are gonna allow those cells to get new mutations that are, some of them are not gonna be usable, but the few of them that are usable, they are gonna be they are gonna create cells that are more resistant and are gonna proliferate after sometimes millions of them, and they are going to acquire these new mutations like resistant to cell death. So these cells are going to get immortality. The regulation of cellular energetics, they are going to be able to take all resources of energy available. And they're going to produce some inducing angiogenesis that is going to give more blood supply and more nutrients to the tumor. They're going to activate invasion metastasis, so they're going to be detached of those cellular junctions and fly away through the vessels and cause metastasis, and so on. But the most important is among those mutations, they are going to activate some mutations that are going to allow them to avoid the immune destruction. So that's what's going on. What is going on is that these cells, these tumor cells, they know by some evolutionary intelligence, by trial and error, that after some mutation they are going to develop weapons that are going to be more efficient than the anti-tumor immunity that our body has, because we had all these anti-tumor immunity weapons. We had several cells that fight these tumoral cells, several cytokines that stimulate our response against these tumoral cells. But these guys, the bad guys, after hundreds, millions of mutations, they are going to acquire this another counterpart of the weapons that are necessary to counterattack this anti-tumor immunity. But we know some of those weapons. As we described previously, we had the CTLA4 and PD1 molecules identify that these bad guys use against us. They use this to put a break to stop the immune system to work. And when they use this, they're just going to stop the immune system. And the immune system is going to just get dormant. It's going to sleepy. And then these bad guys are going to proliferate. So if we identify that, we can put some worries on them, and we can finally destroy these tumoral cells. So we're going to see how does it work. When this happened, because by this moment, now we know how to conquer nature. We are no longer in the hands of fate. We are no longer in the hands of evolution. Let's call it that. The evolution is not any longer in the hands of the nature. We are able to control, create new particle-like virus. We are able to modify genes. We are able to express new receptors in cells. We are able to replicate desirable characteristics in not only in the human cells but in other species. So the evolution has taken another course now, and this is going to change not only medicine but the whole course of the humanity. We are going to be able to maybe create some mutations that are going to allow us to survive in other planets. Let's say like that. So this is the future. Well, we have the T cells. The T cells, as we know, remember, they're going to be activated by these macrophages. Remember the Don Corleone, El Padrino, Godfather, is going to present, the macrophage is going to present with the major histocompatibility complex the ID of the pathogen of the tumoral cell to the lymphocytes. We can see here, major histocompatibility complex is going to present the ID, the peptide, to this T cell receptor of the lymphocyte to being able to identify this as foreign. Okay, you're foreign, I can identify you. Now the second step is going to be activation, and this is the molecule CD28. CD28 is going to be activated, and then it's going to be identified, is going to be assembled by this other molecule, and then the whole lymphocyte got activation after the contact of these two molecules, TCR and CD28. So after that, activation means you are going to get clonal expansion. So it's going to be, this lymphocyte is going to reproduce, it's going to create millions of lymphocytes, and it's going to be hyperactive, and it's going to start to fight the invader, the foreign antigen or the tumoral cell. But there is a problem. If you let that response to go on without stop, without a break, this is going to be too much, and the fighting against those cells can become in an autoimmune disease. So immediately you activate the lymphocytes, immediately the nucleus of the T cells is gonna start to produce the brake to the immune response. The CTLA4 is the brake. It's gonna be produced and it's gonna be expressed in the membrane of this lymphocyte. So after some time of activation, finally we had the CTLA4 expressed in the membrane of this lymphocyte. And what is gonna happen? This is gonna move this, remember CD28 that was activating, positive activation, is going to be displaced, and then CTLA4 is going to produce a down regulation that is going to stop the proliferation of the lymphocytes, stop the hyperactivity, and it's going to get dormant and probably apoptosis. This is right at some point. Infection is okay, but when you are fighting a tumor, this is not good, because when you downregulate the lymphocytes, then there's not going to be response, and then the tumor is going to continue proliferating. So what's the solution? The solution is these guys, so Nobel Prize winners, has developed some antibodies that are going to blockage the CTLA4. You see the CTLA4 here, activation CTLA4. No, now it's not activated because there is an antibody, blocks the CTLA4, and then the CD28 continue activating, and we have again a lymphocyte that continue active after the exposure to the infection of the tumoral cell antigens, and it's not going to be any longer downregulated by CTLA4 because it has been unactivated. It's going to be blocked by this antibody. So that's how does it work. Same here, we have the CTLA4 by the T cells. It's going to be by the tumor cells. It's going to be activated. Then this means there is a break for the immune system. The immune system is not going to work, and the cell tumor is going to proliferate. What we have here is the antibody that is going to block the CTLA4, and then the lymphocyte is going to be activated and it's going to attack the tumoral cell that is going to die. We have two examples here. We had two groups of patients. This is untreated patient, and this is the patient treated with CTLA4. In the first group, we saw here the vessels, the blood vessels. We saw here not too much activity in this patient, but when the patients are treated with CTLA4, then there's going to be break of the immune system that has been pressed by the tumor is going to be removed. You're going to cut the brakes, and then you can see here around the vessels how these blue molecules that are called ECAM are going to be expressed in the blood vessels, so that the lymphocytes and other immune cells are going to be attached to those blood vessels and are going to get inside those blood vessels and get inside the tumor. So it's one thing. So now we see the same patients, but not in the blood vessels, but inside the tumor itself. So the first group here in the upper right that has not been treated, we saw almost no cellular activity of the immune system. So the CD4 or T helper cells and CD8 or cytotoxic cells are not present. So just some regulatory lymphocytes that are going to decrease the immune response. But what about the patients when we cut the brakes of the immune system? So we give CTLA4, and these patients suddenly get this overpopulation of lymphocytes inside the tumor cells. So they are going to proliferate, get inside, and we're going to have this huge response of these cells doing what they do, killing cells that are infected or got mutations. So these are the results of the studies. We had here is a mouse trial, just implant some cancer in this colon cancer in the mouse, and they just put like two control groups, and after some days of treatment, they notice how the tumor start to grow in centimeters here, and grow in the control groups, and grow, proliferate, and got really big, those tumors. But what about the mouse in which the CTLA4 was completely obliterated, was removed from the mouse genome? Well, if you remove the brake, then the immune system is gonna get nuts, and as you can see here, the response barrier, and there is a complete decrease in the size, shrink of the tumor, and disappear, and there is no relapse of the tumor. So that's it. How does it work? It worked really. We see here in a real patient, human patient, and 2001, when the first trials of these medications were launched, we saw here this patient that was previously treated with interleukin-2. That is not specific, but it's a general response that caused so much side effects and inflammation. This patient has a lung mass here. There's a tumor, a metastatic melanoma, and got probably some consequence of inflammation in the pleura to the interleukin-2. So they decide to switch to these new medications, and they give CTLA-4 inhibitors. And what happened? This is the patient after the new medication. So there is no effusion, there is no tumor after 10 years, the follow-up. So this patient that normally die after 1 year or less with these metastatic melanomas, this patient after 10 years is alive and with a complete, let's say, no recurrence of the tumor. So these are the results of the studies after 10 years of follow-up of this first group of patients. We saw here that not all the patients react. Here we had this gap. This is 21% of the patients that react, and after the medication was stopped, after 1 or 2 years the medication was stopped, this patient continue alive. So it's a complete relapse of the tumor. There's no recurrence. We can call it cure of the tumor that never was seen before, because normally these patients after 1 year, between 1 and 2 years, all of them die. But you can say that this is just a small percentage of the population, and it's true. It's true. Not all patients react to the tumor, but this is a beginning. And what this shows, shows is that the monotherapy, in this case, just with one CTLA-4 medication, it shows some response in some patients, some specific patients, but not all of them. But what if we do the following? So we had, again, these are the non-responders. So we had in red CTLA-4 medication. We saw that the results are comparable with the no treatment, or with a vaccine. And this is the green, a vaccine against cancer. So in the three groups, there is no response. These were not the no responders for the treatment of CTLA-4. But what about if we use combination therapy? So in the 4 group, they not use only CTLA-4, but they combine with the vaccine against cancer. And what was the result? You see it, both combination, a complete relapse in the no relapse, is a complete shrinking of the tumor. It was not the tumor was not developed in this melanoma cells. So that's the future. The future is not the monotherapy when we talk about immunotherapy, but the combination. 2 medications or different, or coadjuvants, to bolster the immune system, because the idea is to get, when there is no response, is because the immune system is not sufficiently activated by this type of tumors. And then you have to bolster the immune system to activate those cells of the immune system so that the medication that has been developed can work. Well, we have the second medication that works basically in a similar way. So we have our cytotoxic T cell here in yellow. This is the lymphocyte CT8 T cell that got an encounter with this tumoral cell. The tumoral cells has developed some mutation that expresses a PD-1 ligand that is going to be in contact with the PD-1 molecule in the lymphocyte. And remember, this PD-1 is a brake. It's going to stop. It's going to get to sleep this lymphocyte. So when you activate this, you're just going to put sleep, and the tumoral cells know that. But now we know that, and we can do something about it. So again, when the PD-1 molecule is activated as a break of the immune system, these T cells that's supposed to be attacking the tumoral cells are going to go apoptosis, decrease the proliferation, the cytotoxicity, and it's going to downregulation in all ways. But now we have this, an antibody, monoclonal antibody, anti-PD-1. So anti-breaks of the immune system. When you apply this drug, this is going to blockage the break, and you're just going to have the gas. So just going to get speed. So this is going to pass from this cell, this is going to die, and it's not going to produce any response to these cells that is going to produce a lot of cytokines, and it's going to really cause a significant damage to the cancer cells. So it's like this going from David Banner to the green guy. So, but what's the problem with this? When you go from this and you get the medication and you became in this, what could happen when you got hold in a crystal glass house? There's going to be some damage. This doesn't happen all the time, but these are the side effects. This is the toxicity of these new medications, all kind of inflammation, because you boost the immune system is going to produce inflammation, and you're going to have the inflammation. So you can have in the skin rash, pruritus, liver toxicity, you can have some colitis, that is a serious side effect, and pneumonitis, that all of them can be treated by corticosteroids. They are, all of them are can be controlled, and then the patient can do it very well with the medications if this is controlled and the side effects is not so severe. The only side effect that causes some permanent damage is the hypophysitis, because if you cause some inflammation of the hypophysis, you're going to cause some some damage that is going to be permanent, and then you have to provide some hormonal therapy for the rest of the life, some thyroid hormones, corticosteroids to supply this damage. But if you said that you have cancer, metastatic melanoma, well, there are two ways: or you face the side effects, treat them, or you die. So I would prefer to face the side effects. But despite of that, all the quality of life has shown to be much better with the patients with the new medication, immune therapy. As we can see here, the regular patients with the chemotherapy, the quality of life is quite below the population, normal population. And it's going to keep them until the patient most of the time dies, like in this case of lung cancer tumors. By the other hand, with the new medications, immune therapy, the patient is going to go, if they are responders, they're going to get back to the normal quality of life. And these patients, the difference with this one, the chemotherapy, probably you're going to see it in the emergency department, the house doctor, or get admitted in the hospital. But these patients with the immunotherapy, they are the ones who after a couple of weeks, they are going to go play golf, fishing, or jogging, whatever. So it's a big difference between the side effects and the quality of life. So far, this is the type of tumors that they have some response against this medication. Among them are the melanoma, renal cancer, non-small cell lung cancer cells, head and neck tumors, etc., etc. The characteristics of these tumors is that they are the more aggressive. Like the melanoma is caused by the thousands of accumulative disruptions in DNA because of the radiation of the sunlight. In the lung cancer, of course, the carcinogenics of lung. So when you have tumors that are really malignant with a lot of mutations, that is an advantage for this kind of medications, because more mutations that you get in a tumor cells, the more disrupted proteins that are going to be expressed. And then the immune system is going to be able to catch in an easier way those mutations, identify and attack those tumors. Because if we have a highly immune variability in these tumors, just by cutting the brakes that stop the immune system to work, this immune system is going to go very fast and is going to attack these tumors. By the other hand, the tumors that are no responders for those medications are the, for example, the tumors of the childhood, because the childhood you don't have too many mutations. You get more mutations in your cells as you get older. So the tumors in the childhood are no responders. They are other like prostate, pancreatic cancer, some types of colon cancer. But as we saw before, when you have these new medications and you get combination therapy to booster the immune response inside those tumors, like for example, you create some inflammation inside those tumors, some of these tumors that were not previously treatable by this new medication became treatable by this new medication. So nothing is 100% accurate. So this is a genomic landscape of 5,000 human cancers. So remember Project Human Genome? It was in 2003. It lasts for 3 years and it cost $3 billion. It was a lot of money and a lot of time. Well, after more than 15 years, we have now the tools, the technology that allow us to do almost the same for a price that is not $3 billion, but a couple $1,000, and it's not going to last 3 years, but in a couple of months you can have a landscape of genes to being able to identify the more frequent and potential mutations that can lead to some types of cancer. What has been learned from this? This study shows that the variability of every single tumor is huge. So for example, we have breast cancer, and we have every line here is a patient, and we have the prevalence here of the different mutations from the more common to the less common in the bottom. What we have here is that there is a lot of variability in the mutations with these tumors, and this is not only with breast cancer but with all of the cancers. So that's a challenge, because if we thought like that, it is very difficult for us to fight this variability with the immune therapy, because if you develop one immune response for a specific mutation, like in a vaccine, then there's going to be hundreds of patients with the same type of cancer but different mutations inside the cells. So vaccine that works for one is not going to work for 100. And our immune system is the same. If the immune system launches a response that is effective for a tumor cells, it's going to attack, destroy those tumor cells. But after some hundreds of mutations, thousands of mutations, there are going to appear some cells that have some different mutations, and then the immune system is going to be blind because it's not going to recognize these new mutations. So that's how the cancer works, and how is that difficult to launch a response against the cancer. But here we just talk about CTLA-4 and PD-1. These are just two molecules that we in the last 20 years has been created, these new medications, wonderful medication, but we have much more other molecules that are potential to be studied for create new medications. We had inhibitory receptors like CTLA-4, PD-1. We had many more. There are more than 40 molecules now that has been studied by the laboratories, pharmaceutical companies to develop new medications. So there is a huge scope of new possibilities that to develop new medications to treat cancer for several these different directions. So this is the future, and this is not going to stop now. It's just the beginning, and this is really going to change the history not only of oncology but the medicine. So this is very, very, really interesting and really changing of some paradigms in medicine. So the final idea is this: is just we have the bad guy, the tumor cell that is got a mask and has a stop signal to stop the immune system. So the thing is to remove the stop sign and remove the mask, and then kill the guy. New therapies we have like this: CAR T cells, chimeric antigen receptor T cells. We just take the lymphocytes from the patient. We isolate the lymphocytes, and then we infect this lymphocyte with some viral that is going to carry some additional genetic information to be implanted in the genes of this lymphocyte. Then this lymphocyte is going to become a super lymphocyte, super agent that is going to be able to express new receptors and is not going to be fooled by the tumor cells. So these new lymphocytes are going to be reproduced, monoclonal expansion, from a couple of them to millions of them, and they are going to be put again in circulation inside the patient, and they're going to go attack direct that tumoral cells very effectively. And this is developed a response of almost 100% in some kinds of blood cell tumors like myelomas. We also have this synthetic virus that shows a good response to create inflammation inside the tumors, that is going to act as a booster for the immune system. So the immune system that does not identify a tumor, when we inject those tumors with this synthetic virus or modified virus like measles or herpes, that are going to be modified to do not cause disease but to cause inflammation. And then when you cause inflammation, the tumor is going to be much more susceptible to be a responder for the immune therapies. So finally, we have this patient. He has been treated with these new immune therapies. We see after 25 days of treatment, the tumor seems to grow. And if you talk about chemotherapy, this is a no responder, and you have to change the chemotherapy to stop it. But in this case, it's different. So we have here day 25 of treatment with immune therapies. What happened after 9 days? 9 days after, these tumors that were so big here just disappear. There is no tumors anymore. And what about 3.2 years after? Still there is no tumor. There is no a relapse in the cancer. So what happened here is that at the beginning, the tumors, the metastatic tumors in this liver, grow because there is a right response, and the lymphocytes, like a lymph node in your, you see in your neck, when you got an infection in your throat, you had a swelling of the lymph nodes. It's actually the same. You got swelling of the tumors because it got infiltration and inflammation by these lymphocytes. So this is a nice response, and 3.2 years later, there is no relapse of this tumor metastasis. Complete relapse, so you can call it cure. So remember, this is a control, this is a standard therapy. It's a case of melanoma. We saw it how the standard therapy, chemotherapy, doesn't really increase the life expectancy for a couple of months, but in the end, all of them used to die. With the new therapy, we have this gap. More than 20% of the patient response and get a complete relapse of the tumors, let's say get cured. But now we got the combination therapy, and we expect that is going to be more than 80% of survival rates and complete relapse. So this is the future, definitely, and that's a very good news for the patients with cancer. And we hope that it's going to be not only for few specific cancers, but for all, at some point, almost a big majority of the cancers, with the new combinations and boosters and coadjuvants for the immune system. So this is a guy that started the history. He didn't know quite well what was he doing, but he is the father of cancer immunotherapy. This is his nemesis. This is Dr. James Irwin. So this guy started to develop some approach to treat cancer. He just reviewed his patients because he was an oncologist surgeon in New York, and he saw that after the surgical procedure, all the patients died because there was not big other tools than surgery. But he noticed that in his files that one patient survived after a sarcoma, and the patient who survived, it was because he got an infection of the surgical site, and he got an infection after he got a huge immune response, because by that time there was no antibiotics. The patient was cured. So he tried to reproduce that, and he used to provide or infect those wounds after the surgical procedures. And some patients got much better because the immune system actually started to fight with more strength the tumor cells that were remain. But there was a lot of problems also with sepsis because there was no antibiotics, so a lot of patients died with sepsis. So the second part of his observational trial, we call like that, was to kill the bacteria with heat. And after he killed all those bacteria before to inject to the tumors, there was no infection, of course, and continue to have some very nice response to these tumors. And they call it the toxin. Well, unfortunately, and this is an example of that. You see here this tumor and this patient with a sarcoma in his neck spread to the cheek here. After the application of these toxins of dead bacteria, you see that a shrink of the tumor, and this patient survived for several more years than the patients that were not treated. So it was a success. Unfortunately, his boss, who was Dr. Ewing, didn't like that because he started to get a lot of money from the machines that produce radiation. So it started with the use of radiotherapy, and he started to say, let's say, bad press, no fair treatment for this guy who was doing very good job. It was like the battle between Edison and Tesla. So finally he died, and his job was forget for more than 60 years. And well, this guy got the well known, but it was forgotten in the history for a long time. But now we know that the results of this guy were much better than him. Well, these guys are the heroes of the day, Nobel Prize winners. And we see here in the CTLA4 and PD-1 molecule was discovered more than 30 years ago, and more than 20 years in those some cases was the development of this new medication, the CTLA4 and PD-1 blockers. After more than 20 years of work, hard work, this just received the Nobel Prize. So it's a lot of effort, and a long time has happened, but it paid price. So these were the guys nowadays. It was before. So hard work pays, and that's it. A lot of opposition and a lot of the obstacles in their way, but they succeed. So that's it. That's the presentation. I hope you enjoy it. Remember, this is the battle against this Death Star. We know the weapons now to destroy it, destroy the tumor cells. So we hope that this is gonna continue for a long time of improvements and sophistication in these new weaponry to attack these Death Stars of tumors in our body. So this is the last part, and for any question. Well, thank you so much for your attention, and we hope to see you in the next academic activity. The next 13th of December 2018 is we're gonna have a talk about thyroid disease. And thank you so much for your attention one more time.